This is Chapter 9, Small Volume Parenteral Preparations. Learning objectives for Chapter 9 include recognize the origins of small volume parenteral preparations, in particular with antibiotics, understand the USP Chapter 797 procedures that must be performed prior to sterile compounding procedures, identify the critical sites of various small volume parenteral preparation supply list and describe compounding situations in which certain supply items should be used. Discover the USP Chapter 797 procedures that must be performed during small volume parenteral preparations. And lastly, demonstrate effective technique in the preparation of 2 small volume compounded sterile preparations. This will be a component of your process validation of the lab portion of this course. To begin, let's discuss small volume parenteral preparations. These are generally known as SVPs. They're sterile solutions that typically have a volume of 25, 50, 100, 150, or 250 milliliters. Most of the solutions that you will make will be either 50 or 100 milliliters. 250 milliliter small volume parenterals are given as an intermittent infusion, which varies or differs from the 250 milliliter drip solutions that are considered to be large volume parenterals. In general, these solutions are neutral, isotonic, and isoosmotic. The majority of the small volume parenterals we compound will be IV piggybacks, or what are commonly known as IVPBs. A piggyback is comprised of a small volume of a base solution and an additive medication. The standard base solutions are the same or similar to the large volume parenterals. Most commonly, they will be D5W or normal saline. They may also include half normal or sterile water, but the most common are D5W and normal saline. Unlike the LVP given for hydration or as a continuous infusion, a piggyback is used solely for the intermittent IV administration of a medication according to a dosing schedule. Intermittent infusion is accomplished by piggybacking the small volume parenteral through the tubing containing the patient's primary IV solution. So there are a number of IV piggybacks that are stable as premixed, shelf-stable, or frozen products. So I've given some examples here. So this lidocaine is a pre-made, shelf-stable bag. Nitroglycerin, this is a pre-made, shelf-stable, but this medication is actually stored in glass. And lastly, this picture is of one of those frozen, stable products. Once removed from the freezer, it's brought to out to what we usually call a defrosting table, where it is allowed to melt down, and then once all of the ice has melted out, it's dated and stored in a refrigerator. We don't ever want to let these frozen products come to a full room temperature. We want to defrost them until just all of the frozen particles have been melted. Other types of vial and bag systems, so we have the Mini Bag Plus on this side that we talked about in the first couple days of lab, and then the AdaVial on this side. So those are also shelf stable. The majority of the ordered IV piggybacks, however, are compounded. So when we talk about identifying the parts of an order, the prescriber will generally indicate the medication and the dosing interval, or even a schedule, but doesn't necessarily identify the base solution. So, for example, here it says give ampicillin 100 milligram or 500 milligrams IV piggyback now, but we don't see anything about a base solution. Here we have Zosyn IV piggyback every 6 hours, or Flagyl 500 milligrams IV piggyback every 12 hours. Again, it doesn't give us our base solution or the volume that it will be put in. That's usually determined by a protocol, or as we found in the first lab, you can look up what's the appropriate volume and run time for those IVs. The pharmacist considers several factors when choosing the most appropriate base solution and volume, including the compatibility of the medication with the base solution, the length of time over which the IV piggyback is to be administered, and the kidney function and hydration status of the patient. Also, minimum or maximum concentrations that are required for safe administration of the drug. So all of these pieces have to be kept in mind when determining the appropriate base. So finding the proper resource is very important. So here there's an example of a Micromedics page. Micromedics is kind of our go-to in a hospital facility. It's an online resource and it's scientific. Global RPH, although it's a quick go-to, is not necessarily a true verified resource. The other resource is your Trissel's Handbook on Injectable Drugs. Like with a large volume parenteral solution, incompatibility is also a concern with your small volume parenterals. So in addition to the risks, they're due to the incompatibility issues. So we usually piggyback these onto another line. So incompatibilities are potentially more common. We want to make sure that a precipitate doesn't form that could clog the tubing and cause injury to the patient. The primary tubing or the lock must be flushed after the piggyback administration. If the patient is receiving an IV solution as a primary line, the flush is just normally performed by lowering the empty IV piggyback with the secondary tubing attached to the height. That will then allow the gravity to allow the primary solution to flow back through that secondary tubing. That's done by the nurse. It's just here for you to understand the concept. Patients without a primary tubing, if they have a HEP lock or a saline lock in place, it will either be flushed with normal saline or heparinized saline solution. Administration of an IV piggyback, they're administered over a short period of time. That's intermittent. Most of the IV piggybacks are administered by piggybacking them onto the primary line. So here is an illustration of a piggyback. So this first diagram here, you've got your primary infusion running through your primary line. Your piggyback is connected through the Y site terminal with secondary tubing, which is generally shorter and doesn't have any injection ports into it. The piggyback is actually hung higher because that forces gravity for it to kind of shut off the original piggyback, the original infusion. So you see here by these arrows that the medicine's running through this line. Once the medication has completed and the bag is empty, there's nothing left. So then the primary infusion will again once start running. So this has no more gravity. So what the previous slide was talking about was flushing this catheter on the IV port of the Y site with the original solution. So this bag would be moved down lower than, come on, give me my pen selections, there we go. It would be moved down this way so that it would be below that line, and then the fluid would flow back through this port, flush the line, we lift it up, it flushes back out, and then this line can be detached and the primary infusion would be left to run. Most piggybacks are given over a short period of time. They're administered through the primary line. Occasionally, a piggyback is administered why that was repeated, I have no idea. All right. Well, let's go back. So it's administered through the primary line. Now, if they don't have a line, we may have a secondary tubing that's directly into an injection port via the vein. This is known as a HEP lock or a saline lock, or just commonly referred to as a lock. So right here is where that lock is located. So they have it into the patient's vein at this level, and then that secondary tubing is attached at that port. All right, let's talk a little bit about some potential complications of parenteral therapy. Now, this video doesn't have any dialogue, and it's kind of got some watermarks on it, but it kind of gives the idea. So in the previous chapter, I said that I would talk about extravasation and infiltration and tissuing and cellulitis a little bit more, and that's what this video illustrates. So to begin with, this video shows improper intravenous injection into a hand site. So being that it's copyright protected, it's got this watermark. So the cannula is being inserted into a hand site. So they use an IV needle to place the cannula into the vein. Now we have a cross section. So this needle has gone in. This is the HEP lock cannula that's going to stay behind. So that's been inserted using a needle, and this catheter remains. They're going to remove the syringe with the needle attachment and leave that hard plastic catheter in place. Now that can be used to attach an IV line or a syringe. So there's the catheter port in place in the hand and the attachment of tubing. So they're going to give the illustration of giving a bolus dose using a IV push using a syringe and the effects as administration is done properly. So this one is a slow, gradual injection. You see the medicine come out and it flow through the vein, and everything stays normal. The next illustration is going to be where they push this too quickly. So it forces all of the medication into the vein. When it does that, it can cause damage to the vein, as illustrated here, and then the medication can start to seep out and infiltrate into that subcutaneous tissue. And it starts to damage that tissue. It can cause toxicity in the cells, cause swelling and inflammation or cellulitis, which can result in infection. And as it does that, the vein also may swell, phlebitis, causing spasms. And as the tissue above continues to swell, it can actually push down and compress that vein even more, putting pressure on that blood vessel. And at that point, we also have extravasation. That needle's not fully in the vein anymore. As that damage occurs, you start to get inflammation and swelling, causing cellulitis, and also disrupting blood flow, which can cause thrombocytes to coagulate and cause thrombosis, and block the blood vessels and constrict the airflow, the blood flow, which then could potentially cause necrosis for lack of blood flow, which could necessitate an amputation. So there is one of the concerns of several components of improperly administered IVs.